Okay, everybody, thank you very much. We will try to reward punctuality, and we are here at 5:30. You guys all represent either consumers or patients or survivors of neuroendocrine tumours and carcinoid tumours. It's a rare tumour type, as we know. What's interesting, though, we've got a very big program of people. I think we've got around probably a quarter of all the oncologists in town that treat all the high-volume cancers. But while you may think that you are on your own, you've got a lot of doctors that are very interested in a very small sample of tumours that inflict our community. Paul Catrice from the WA Clinical Oncology Group and the Cancer Council, thank you for coming along. It's a great collaboration between the national consumer-focused body for this set of tumours, the Unicorn Foundation. So we also welcome Kate Wakeland, the Unicorn Net nurse for the nation as well. So many of you may have had telephone contact or seen or heard of Kate's work and her supportive roles for you guys as well. I mentioned earlier about a small group of, or quite a large group of clinicians that have got some interest in neuroendocrine tumours, and we are going to hear from all the leaders in town today. And starting off with Dr. David Ransom, who is a medical oncologist at Fiona Stanley Hospital and historically Royal Perth as well, and this hospital, and currently also has a very significant role as a cancer bureaucrat for all the oncology services of the state, and that's the WA Cancer and Palliative Care Network. So I will leave it to David to fly away with his presentation now.
Thanks, Paul. So this is an unusual event for me. I often speak to health professionals, but it's very rarely that I speak to consumers as a consumer group, and probably this is a new experience for you as well. But we'll give it a go and see how we go. So just to give you some background, today we're talking about neuroendocrine tumours, and they have a spectrum of behaviour from very slow growing cancer to a very rapidly growing cancer. Sometimes when you do Google searches, you might see the term carcinoid tumour. Carcinoid tumour was a term that came along, I think, in the 1800s by Professor Virchow, because he said these weren't usual cancers. We've tried to move away from that term, but still a lot of people refer to them as carcinoid tumours. But we will try to remember to call them NETs. Carcinoid syndrome is still an okay term. Carcinoid syndrome refers to the syndrome that about 10 to 20% of patients have, and that is predominantly flushing and diarrhoea, and sometimes wheezing. So a small proportion of you in the audience may have the syndrome, and that's due to an active hormone secretion which causes those symptoms. Tonight we're going to talk about low and intermediate grade tumours. We are not going to talk about high grade tumours. I believe that they are a separate group of tumours. They may look a bit the same under the microscope, but really they're a lot different. And so they have an entirely different spectrum of treatment, and we aren't going to talk about those. Low-grade NETs can arise in many sites, but most commonly in the distal small bowel, rectum, pancreas and lung. And we will touch on most of those. However, the majority of patients have a small bowel or pancreas primary. Do all these tumours behave the same? Jumping there. Not really. I think that even though small bowel neuroendocrine tumours and pancreatic neuroendocrine tumours may look the same under the microscope when a histopathologist looks at them, they really, from a natural history, behave differently. From a treatment perspective, they behave differently, and they have a different natural history, and most of the time we will split them out So we'll talk about bowel neuroendocrine tumours, and we'll talk about pancreas neuroendocrine tumours, and we don't cross over very often. Some treatments work for both, all of them. Some treatments work only for one, or for pancreas. So what I want to talk about tonight, after giving you that background, is how do doctors evaluate new treatment? You're bombarded with information all the time about new treatments. Should I do this? Should I do that? What's the best way to go? So I'm going to talk about how doctors read the medical literature and what to look out for as to what doctors would take notice of. I'm then going to give a few examples of that. I'm going to talk about the NETA study, which is a study which has recently been published. And then I'm going to talk about our local Australian study, which is CONTROLNETS. So evaluating new treatments, you read something on Google, you read something in the newspaper. In the West Australian, on average, there's a cancer article approximately every 2 weeks. Generally, it's hyped as normally the headline would be cancer breakthrough, would be the standard headline. The other headline would usually be an individual patient who's either done incredibly well or it's a really tough situation and evokes a lot of sympathy. They're usually the flavour of the media stories. So when you see a new treatment described, you have to ask yourself, is this the holy grail that we're looking for, or is it just a whole pile of bull? And I would like to thank Bert, the blonde-actotane bull, for his contribution to this talk. And isn't he handsome? So, influencing decision-making. So one way of evaluating whether a new treatment works or not is growing cells in tissue culture and then adding in some agent to see if the cells die. Now, as doctors who treat patients, we don't take very much notice. In fact, we take no notice of this data. This situation is incredibly artificial and has no relevance to real people. And I did run this past through some sort of moral compass, and they said because I included Jennifer Hawkins and George Clooney, this slide was okay. So you can move on from tissue culture to rodents. And, you know, this is a common animal model. And you take cells from tissue culture, you can inject them either subcutaneously or into the tail vein, and then you can see what happens to this poor mouse, and you can evaluate whether this treatment works or not. Again, this is a highly artificial model, and generally speaking, it creates ideas, but it is not practice changing for routine patients. Case reports. So this is when one or two patients are presented as doing incredibly well, but only one or two patients are presented. And generally speaking, as medical practitioners, we do not take notice of case reports. Most of the time, you can generate a series, and you know, in this rare group of tumours in Western Australia, we now have 18 patients on our study in a period of 6 months. So when you see results for one or two patients, you think, well, this is very unusual. I can't really use this as a take-home message. So beware of the star patient. it's easy to understand, but generally, are the results applicable to the broader population? Probably not. And how come there's only one? A series of more than 20 patients. Now this is starting to get interesting. So if we take a group of patients who all have much the same thing, there's at least 20 of them and hopefully 40 to 50. They've all had the same treatment. We really start to look at, wow, this might be representative. This might be something really good. We have a look at it. We have a think about our past experience and make some decisions on it. However, the question will always be, are the patients in the study the same as the patients we're seeing in the clinic? So randomised trials is the usual thing that we go on. So that means that you're able to compare 2 or more treatments, and what happens in a randomised study is that patients who all look the same come along, and we then do the randomisation, and the doctor and the patient don't get a say as to which treatment you get. You're then allocated that treatment and the results, and then subsequently followed up to see what happens. And what that means is that the 2 groups are comparable. It was a chance event which treatment you got, and so therefore the groups should be comparable, and therefore the results are very interesting and comparable, and it's the way we usually evaluate new treatments. In most cancer trials, there's no placebo. What I mean by that is a dummy tablet, and there's usually not blinded. In a blinded study, it means that the patient and the doctor don't know what treatment the patient's getting. It's useful when you're looking for psychological endpoints. It's a very useful thing to do, but in cancer trials, usually it's not so important, so it's rare for the studies to be blinded. So this is a study that's relevant for you guys. This is what a trial that we would take notice of, and this is what they look like. So it's published in the New England Journal, reputable medical journal. It was published in July 2014 by a whole heap of guys. And this is called the CONTROLNETS study. So it's lanreotide for metastatic enterohepatic neuroendocrine tumours. In this group, they lumped small bowel and pancreas together. And this study was also unusual in that it had a placebo. So they had a placebo injection versus lanreotide, 120 milligrams every 28 days. And this is what the progression-free survival curve looked like. So as you can see, this is what it looks like. This is the lanreotide group here, and this is the placebo group here. So what does progression-free survival mean? Progression-free survival means that the cancer didn't get worse on imaging. So if the cancer's getting worse on imaging, we call it progression. If the cancer's not getting worse, we call it stable disease. And lanreotide has been shown to delay progression in a proportion of patients. So when I look at that curve, I look at it and I think, is that biologically significant? Because sometimes if you fiddle around with the X and Y axis, you can make a split in the curves and it's not really biologically significant. But as you can see, they haven't fiddled with the X-axis or the Y-axis, and there's a pretty big split between those 2 curves, and that has now represented a treatment-changing study. This is the NETA study. This is not published in a journal at the moment. It's only published in abstract form. So we've had peptide receptor radiotherapy or radioactive treatment for neuroendocrine tumours for more than 10 years. That is not the case in many countries, including the USA. This is a US study to look at the role of peptide receptor radiotherapy in small bowel tumours. So it's 177-Lu dotate, which is the same molecule that we use. And patients had to have been progressing, in other words, getting worse on something like lanreotide. So they took patients that were on lanreotide and then they were getting worse, so now what do? So half the patients got, well, this is the sandostatin LAR, it's a very similar molecule. They doubled the dose versus this new stuff, which is peptide receptor radiotherapy. And they followed the patients up, or intend to follow them up for 5 years. So this is the progression-free survival curve. And as you can see, there's a huge difference between those two studies. Now, in North America, this is a practice-changing study. But in Australia, and certainly in Western Australia, we've been convinced for quite a long time that peptide receptor radiotherapy is the way to go, so it's not practice-changing in Western Australia. However, it does form the basis of, this, you know, it goes very nicely into our study, the CONTROLNETS study. So CONTROLNETS is really two studies in one. Patients, there's one arm for pancreatic tumours and another one for small bowel. And for mid-gut neuroendocrine tumours, that's the ones in the bowel, everybody gets peptide receptor radiotherapy as they got in the net, as the experimental arm in the NETA study. So everybody gets peptide receptor radiotherapy, and the question is if you're going to have this treatment, is adding in chemo going to make a difference? So can we make peptide receptor radiotherapy better? Is the question in that issue, seeing from the NETA study, peptide receptor radiotherapy is the way to go in these tumours. So that's the question being asked in that arm. And then in the other arm, in a lot of centres in the world, pancreas neuroendocrine tumours are treated with chemotherapy up front. So the question for those patients is adding in peptide receptor radiotherapy to chemo going to make a difference? We opened in December. In Western Australia, we are leading Australia as far as accrual to this study is concerned. As you can see, we've put on 18 patients, and it's disappointing that the rest of Australia hasn't been as active as we have. But we're getting there. So progress, I think, from the patient's point of view often seems slow. You know, everybody wants something now. But things are slowly getting better, and we're continuing to make progress in this uncommon disease. Thank you.